Morning all. First of all, I would like to thank Dr. Chaitra and AIOS for this opportunity. So I'll be talking about OCTA in DME. So these are the layers of the OCTA, as we know, the coming from the superficial, deep, and outer retina and CC layer, which we are all now quite familiar with. But when it comes to DME, since it involves the blood vessels and the capillaries, we are more concerned about these layers, the superficial capillary plexus and the deep capillary plexus. The instrument what I used for this presentation is the OptoView. We do have many companies that have OCTA now, but OptoView is the one what I had used. So it is said that there are many studies that have shown that FAZ is altered in diabetic retinopathy even before any macular changes they set in. So FAZ kind of increases in size, vascular density kind of decreases. So that's what happens. So this is the angioanalytics. That's a machine-built software that is there, which gives us the post-image acquisition processing. The many indices like wherein you can see vessel density, FAZ area, asaccularity index, and the many more that have been coming up, and many studies that I've done, and even we have an in-house fractal dimension wherein we have seen spacing between large and small vessels also. So there are studies. This is how they do is they do kind of binarize the image, then they skeletonize, and then kind of they see the spaces, they see the FAZ, and they see the vessel density. So when you look at a normal OCT and a OCT with macular edema, these are the red areas are the ones wherein there is capillary, maybe like non-perfusion, not exactly because of the edema there, we can't call it non-perfusion, but these are the areas where there is loss of blood supply or decrease in blood vessels over there, rarefaction. So we did a study in cases with diabetic retinopathy without macular edema. We had seen progressive decrease in vessel density and increase in FAZ over grades of diabetic retinopathy, but it was not statistically significant in both layers across grades, but FAZ also did not significantly change, but the spacing between the vessels changed when the diabetic retinopathy grade increased. So this is a typical case of diabetic retinopathy with macular edema. You can see the altered FAZ, which is more prominent in the DCP, most probably because the section goes through the IPL and the OPL. So that is where you see these dark areas and really can't make out the vascular changes that happen here. So it's kind of an artifact. We need to be careful when we interpret this. So this, when you compare it with an FA, this is an SCP and this is the DCP. These are all 3x3 scans which I have used because of the high resolution. You can see this vascular dilatation and tortuosity. You can see the FAZ break and the macular ischemia here, which is these changes when comparable to FA, the most seen in SCP, but DCP are the main area where things really happen. So another case, you can see macular edema, aneurysmal dilatations. You can see these aneurysms and altered FAZ here, and most probably again we need to check where the scan is really passing through when we really kind of come to a conclusion or say that this is a drop in vascular supply. So the chronic DME, these are the unfast images what you get along with the OCTA image. So this also gives a rough estimate of the extent of diabetic macular edema and the prognosis as such. So this is a case of non-responding DME. The 6 mm scan. The problem with 6 mm scans is the resolution really comes down. So it's really difficult to make out, but you can roughly make out what's really happening. There's too much of vascular distortion here, non-perfusion areas, aneurysms. So this is a corresponding unfast. So we did an in-house study wherein we compared these aneurysms across two machines. So maybe because this was between OptoView and Spectralis. So Spectralis obviously has more B scans. So somehow we found more aneurysms that were there in Spectralis when compared to OptoView. So this is what we have in-house. Our in-house team had developed this, the local fractal dimension. So we can see the spacing between large and small vessels, FAZ, and the vascular density also. So these were the changes. So Spectralis somehow was more able to detect these aneurysms when compared to OptoView. There are many articles which even showed the aneurysmal changes that happen, what really goes on in a good response DME. You can see a good response DME here and a poor response DME here. The aneurysms are obviously more in poor response DME in a DCP layer when compared to SCP in a poor response DME. So then again, this is a case of responsive DME. This is a recurring DME in the right eye and poorly responsive DME, but again recurring in the left eye. So you can see quite a lot of changes like drill and outer receptor, outer photoreceptor damage and other things. So, but when you look at the FAZ and the drop in areas, it's more significant. Even the aneurysms are more significant in the poorly responsive DME when compared to a good responsive DME. But this is a recurring case, so that's the reason you can see the chronic changes that's happening there. So many studies again showed what really happens, what are the risk factors for poor visual acuity in a case of diabetic macular edema and OCTA. So they found that increased irregularity in FAZ and extensive damage in the DCP and larger FAZ area, and when there's initial high foveal thickness, these are the risk factors for poor visual acuity. And then again, there are studies again which showed that in a poor response DME, you can see the disrupted OPL. This is because of the disruption here, or outer nuclear layers kind of breakdown. So when there's a communication, you can see the drop in vascularity over here. So coming to the importance of DCP, now we know that DCP is more important in DME when compared to SCP. So the synapse between bipolar cells and photoreceptor cells here happens in the wall. It's because it's a voluminous layer, and since OPL acts as a fluid barrier, intraretinal cysts between inner and outer nuclear, they communicate to the disrupted OPL, and this leads to the eventual damage and non-responsiveness. So DCP again supplies about 15% of oxygen to photoreceptors and inner and outer nuclear layers. So this layer is extremely important for vision as well as response to DME. Then again, there are again studies which showed that where do the aneurysms really lie? Do they lie within the edema area or do they lie outside the edema area? So it's known that these aneurysms are more seen within the edema area when compared to the outside the edema area, and these are more significant in a non-responsive DME. So this is how it is. Again, DCP has more microaneurysms, and when retinal thickness is more than 400 microns, all these aneurysms are more concentrated in DCP, almost around 91%. So many studies that have shown that where they usually lie aneurysms and all. So the ultimate conclusion is it's morely in the DCP. This is again before and after reduction. You can see the aneurysmal changes. And we should be mindful of the artifacts that can happen. These are because of the saccades, microsaccades, because of the microsaccades in the z-axis. So these are called suspended scattering particles in motion. So these give rise to areas wherein it looks like there's a flow there, but there's no flow there. So we need to be mindful when interpreting an OCTA. So there are again studies which showed that the hyperreflectivity and hyporeflectivity, whether that corresponds to non-perfusion. So you need to Zeiss and AngioView, the difference between the two machines again. So AngioView has a little less hyperreflective spaces here, whereas Zeiss has more hyperreflective. So when there is hyperreflectivity with no SS PAM, then you should consider these as NPA, non-perfusion areas. When there is hyperreflectivity with SSPM, then these should be considered as perfused areas. Then again, when you look at these things, it doesn't mean that there's a non-perfusion and loss of the vessel. Once the edema comes down, the vessels kind of resurface. These are called the remodeling of the vessels. So this also has to be kept in mind. So then aneurysms, even if you follow over a period of time after 1 year also, sometimes aneurysms which have low flow, which are not detected on OCTA, they can remain like that. Maybe the edema never recurs, but in case of recurring edema, you can see that the aneurysms are active and the flow is there. So that is caught by OCTA there. Coming to the salient features, OCTA has shown that DME, when better FAZ and vessel visibility kind of gets better once the macular edema comes down. So the remodeling of the vessels, vessel displacement, all should be kept in mind. The enlarged FAZ in deep capillary plexus, these are basically because of changes in the diabetic macular edema. The many difficulties when you are interpreting OCTA, the differentiation and segmentation is extremely difficult in anatomically distorted scans. So you need to really sit at the machine and kind of see what's really happening. You can't really read a printout and say that okay, there's a non-perfusion. Projection artifacts again have to be kept in mind. The many misleading features like SSPAM, wherein edema and hard exudates can give rise to a suspicion that there's a flow there. So to conclude, it's a 3-dimensional non-invasive evaluation of the structure of the edema. Understanding, I believe it's in a routine practice. I just used to go back and see what's really happening there if there's a non-responding edema, or to rule out macular ischemia. You can even do targeted treatment based on aneurysms. For academic interest, you can see these aneurysms, so what really happens in the CNP areas. Thank you so much for your patient listening.
Thank you, Santosh, for that overview of OCTA. So, from what I understand now, it's basically a tool to prognosticate.
That's
For patients, despite no edema, still having poor vision and probably not wanting to do an angiography every time. So, I understand that as of now, OCTA will still remain a prognosticating tool, or are you looking at a future where we'll use OCTA over OCT for diagnostic or follow up as well?
I think the problem is the artifacts and difficult to kind of interpret directly. I mean, because you are concerned about the flow areas, non-perfusion areas, which is not very easy when you are reading an OCTA. Though you have post-image processing protocols, we do have in-house protocols wherein you can remove these artifacts, but it's again not easy. You can't really go by the face value of it. But if you look back, there are studies which show that a good response to even bevacizumab. They say that the initial presence of good number of vessels, there's a good response, something like that. So you can go back and check, or you can progressively even monitor these scans.
I think one question which I always have in mind, will it totally replace fluorescein angiography for DME? That is the question. Fundus fluorescein angiography, because that's being invasive. I think if that because anyway OCT is done as part and parcel of most of the OCTAs. So that is the big question.
Right.
So what do you feel about that?
I think chronic macular edemas, I mean non-responding, we do kind of go ahead and do an FA there, sir, most of the times. But the aneurysms that are detected by OCTA is not equal to what is detected in an FA. So because of what you call infarction and occlusion. So it's not very easy.
I wanted to ask, is it important now for us to detect every aneurysm, since we are not, treatment methods are different, we are not really targeting. So that's what comes to my mind.
Can I take that, please? So I'd like to say that the concept of the question of OCTA replacing FFA is a moot point there. Every day we are learning new things about OCTA and looking at DM in a totally different way, not just seeing the size of the FAZ. The FAZ itself, there's a big controversy as to whether you have to look at the FAZ as a whole slab, whether you look only at the SVP FAZ, the DVP FAZ. So what does this mean? That it means that every day we are finding new ways to look at a particular problem. The current issue is that we have not enough data to substantiate what is important and what is not important. But that only time will give us. When we started with the OCT, we just measured the central retinal thickness and that was it. Now we look at the type of edema, we look at particles suspended, we look at all these things. So give it another 5 years and OCTA is going to be a different investigative modality in DME. It is the question of replacement of FFA is not there. And another point to that is that we cannot separate OCTA from OCT. You cannot interpret an OCTA image unless you have the OCT right by its side. There are protocols like the Humphrey field analysis, which now the reporting system is going to be like you have to have the corresponding OCT, the corresponding on-fast image, and the corresponding OCT image to really interpret what is happening in an OCTA image.
Well, I invite Uni to start off his presentation. One last question, Santosh. Like how we have quantification methods for OCT, do you have anything where we can, map out which are part of the algorithms to quantify? We continue to monitor the ischemic area, right? Through the algorithms itself. How do you quantify the ischemic area is what I'm saying?
Yeah, you can, but again, you need to kind of change the segmentation and then see.
Manually.
Yeah, that's other problem. You can't really go by
the
most of the studies. They have taken their default segmentation, but if you kind of change, everything changes. Okay. So if you look at the limitations in all these papers, they say that. So the limitations again is the fluid that is there. If it's a flat macula, nothing like it. But if it's not a flat macula, it's not easy.